a consumer might not be into sharing any personal information, but the provider community, I know you guys like to come to these events and network and share. And so if you use the chat feature, and very important is use the drop-down menu on chat that says all panelists and attendees. And in that area, you can introduce yourself to the rest of the group. I recommend, if you're a provider, your name, your organization, and your contact info. And but for everybody who's registered for this event, I'll make a copy of the chat as well as a copy of this recording so that you could reference it or share it with people around you. So really excited about our guest today and the topic. And just to give you a little bit of background, this Dr. DeYoung is a really innovative physician working with older adults, and was brought on board to Capital Caring Health to create something really new and unique. And we had the good fortune of having one of our last meetings, these meetings that we now conduct online with regular frequency. We used to do them, once a month, once a quarter. And one of our last meetings was at the Capital Caring Health headquarters. They have a beautiful auditorium, and Dr. DeYoung and his team sort of debuted this unique home-based primary care practice that they're launching, and that we're going to learn more about today. So let me bring. Okay, so I'm gonna. Oh boy, here we go. Start video and unmute Dr. DeYoung, and then also Deanna from. So we have two guests today from Capital Caring Health. Deanna Chow. Cho. Gosh, I always botch your name. So we're going to get to meeting our two guests here, but before we do that, one of the things that I want to share with you guys is that down below you'll see that there's a little Q&A box on the lower part of your screen. Feel free to click on there at any point in time if there's a question that you would like to ask Dr. DeYoung or Deanna Cho, or the community at large that's here today. We have about 130 people that signed up for this, and they seem to be flowing in as we speak. The other thing you can do is you can raise your hand, and that you'll find that feature by clicking the participants button. There's a button there that says raise your hand, and throughout the afternoon we can call on you and you can verbally ask a question. Okay, so with that, the housekeeping is done. I'm really excited to see you, Dr. DeYoung. We had scheduled this a few weeks ago at the beginning of the COVID-19 process, and unfortunately you had to bail out with a nursing home issue. But I'm curious, I want to hear some of these stories, but first off, just give the audience a little bit about your background and the interesting career path that has led you to what you're doing at Capital Caring Health.
Thanks, Steve. Hi, everybody out there in Zoom land. I don't know about you, but I'm getting a little tired of Zoom calls all day long, as I look forward to meeting you in person again. So Steve, I'm Eric DeYoung. I'm a geriatrician. So I trained in internal medicine and geriatrics, primary care, internal medicine, and then geriatrics. I grew up in Chicago, kind of bounced around through my training to California, Connecticut, and then ended up in Baltimore, where I met these amazing kind of geriatricians who had a house call program in Baltimore at the Hopkins Geriatric Center. And when I was a second-year resident, they sent me out at the end of my long days and say, here are 10 patients, they belong to you. And you're the primary doc for them. And you have to go out and make house calls and take care of them with help from our team. And I kind of got hooked both on geriatrics and house calls back then. That was 1992. And I went on and trained in geriatrics under those same folks and really appreciate how rewarding, but also how challenging it is to take care of people with serious illness who have lots of medical issues, lots of social issues, perhaps family issues, and try to put a team together that takes care of that patient and their family at home, but also in the hospital and across settings until the last day of life. And I find that really rewarding on a team base and for the patients and families. And I feel it personally, it's very rewarding for me. I keep learning, I keep growing, and it's never boring. And it's always challenging. And that's why I've continued to do it, throughout my career. And just a little background, I landed in DC 1999 and worked at MedStar Washington Hospital Center, in part with Deanna for the last 20 years I was there. And then I decided to, after a wonderful run at Washington Hospital Center, I decided to switch in July of last year to Capital Caring Health. And they kind of gave me the opportunity to build new geriatric services in DC, Montgomery County, and Northern Virginia, first focusing on primary care at home, but also all sorts of geriatric services, which we're working on. I'm glad to talk about that with the group. And the only thing I would close with on my intro is Deanna Cho, who you see here, is just part of the team that we work with. Deanna's a social worker. We have nurse practitioners. We have coordinators, and it's a total team interdisciplinary effort, including a lot of the folks on this call and who provide the social and other supports in the community. So the docs are just kind of one piece of the team that is important, but we really can't do very much without the whole team involved. I can't hear you, Steve. Can you hear me?
Oh, sorry. I muted my microphone. Sorry about that. It's all this protocol that we're dealing with these meetings. It's really interesting, as you had mentioned. And speaking of protocol, in the chat, guys, I know this is a pain and I'm hoping Zoom changes it, but when you are in chat, you have to select the drop-down menu that says all panelists and attendees, or else your chat only goes to the panel members. And I know you want to share your questions and your info with the whole group. Okay, so let's kind of dive into this unique program that you've created at Capital Caring Health, and give us, sort of the 1,000-foot vision, and then kind of bring it down to how does a client sign up and how much does it cost?
Sure. So I'll start out with the why, and then I'll kind of go about who do we serve, what do we do, and how does it work. So the why is, the goal is to have a team that brings medical care to elders in the community and helps deliver peace of mind. That's our main goal, peace of mind for the patient and peace of mind for the family. In order to do that, we've chosen first to serve people who are 65 and over. That's one decision that we have made, that we're not right now doing younger disabled folks who have serious chronic illness and need some sort of help getting to the doctor's office. It can be for social reasons, psychiatric, physical, cognitive. They can walk and talk and get around even in their neighborhood. But if it's hard to get to the doctor's office for any reason, we think this program, a primary care at home program, is for you. And so what do we do? So we have to first get a team together of docs, NPs, social workers, and coordinators, kind of a core interdisciplinary team. We make house calls. We make house calls Monday through Friday, urgent visits within 24 hours. We follow the patients into the hospital, and we help coordinate their care into the ER and out of the ER, into the hospital and out of the hospital. So we kind of think of it as a one-stop shop for all their medical needs. We provide 24/7 access. So by phone, you can reach one of our docs or NPs 24 hours a day and try to avoid 911 phone calls. We have social work on our team. Deanna's here, but we have other social workers on the team and tap into support services in the community for social services. And we use mobile technology. So this is not kind of primitive medicine. This is actually really high-tech mobile oxygen monitors, EKGs, x-rays, blood tests, ultrasounds. You can do all of this at home. We do COVID-19 testing at home. We can do essentially anything you get in an urgent care center, we can do at home with our team and the support from Capital Care and Health. So that's what we do. And then you talked about payment. I'm going to touch on payment in a minute, but I would just want to say, where do we do this? And that's a lot of questions are about where. So house calls are by nature inefficient, right? You have to travel all around and drive all around. And these days we're doing some televideo visits, which are more efficient, but to see the patient and to see their home, it's not efficient in terms of time. So you can't serve the entire DMV region off the bat. So what we've decided to do is serve 6 zip codes in Northwest DC and Chevy Chase. It's 2007, 8, 15, 16, and then in Maryland, it's 20815 and 2816, those 6. And in Northern Virginia, we've expanded a little bit. We have 14 zip codes, which I won't list right now. But it's basically inside the Beltway in McLean, Arlington, and Falls Church area. So that's where we do it. I'm going to stop there. Steve, do you have any questions before I go on to
one of the things that I think was fascinating when you were originally launching this program, and it brought a lot of questions and comments at our live event, was, you know, how sort of the structure that dictates the location where you're at. And so, you know, one of the appeals that you made to the group is like, we're starting with these various areas, and we can have a capacity of X amount of clients, and then we can begin to expand to other areas. And it really charged up the professional community because, you know, many of the people there who had clients that were maybe in Fairfax County and not in Arlington were sort of like, oh, I can't wait till they're there. So that's one thing that I'd love to get a little bit more behind the curtains on from you. The other thing that I just want to reiterate, because it came up at our live event too, is for the longest period of time, we view Capital Caring Health as a hospice provider, you know, and so sort of, because I know the answer to this question, that this is primary care, not hospice care, but because you're so well known as a hospice provider, just kind of reiterate the difference between those two businesses.
Yeah, and I would say, you know, Capital Care and Health is very well known as a hospice provider and palliative care. They've been doing hospice care for about 43 years now in the DC area, Virginia area, and palliative care for 10 years. So they hadn't done primary care or geriatrics to speak of until this past few months. And Capital Care and Health has really put its full support behind building primary care services, which are for many years, potentially, of really seriously ill folks, taking responsibility as kind of captain of the ships. Our team is in charge of all medical care. So they do have to become our primary care patients. And we do then use hospice, Steve. It's not either or, right? It's primary care that then brings in hospice when needed. In fact, we now have 50 patients, we're, you know, total so far, not a lot, but we'd love to, you know, get to 300 or 400, and about 10 or 12 of our patients are in hospice, and that's because they've gotten to that stage of life. So, you know, 10 or 20% of the patients might be in hospice as well.
Great. Let's see. There was a question that came in. Judy Tiger asked, hope we'll learn about the background. Okay, good. I think we talked a little bit there about the background of Capital Caring before you arrived. And when did you arrive at Capital Caring? I
actually landed in last July, and it took about 6 months to build the staff and hire new staff. We hired 9 new people to build the geriatrics initial team. So kind of 4 in each area, plus a VP of practice management and myself.
Okay, great.
So we have, go ahead.
Because we're looking at Deanna there, describe who is on the team. I know Deanna and the social workers are a vital part of that.
Yeah, each team, and so there's 1 in DC, Maryland, and 1 for Northern Virginia. Each team has 1 doctor, and in fact, right now it's like a 40% of a doctor, and one nurse practitioner, one social worker, an office manager, and kind of an office nurse to kind of support both teams. So there's about 4 or 5 staff on each team. That's a half a team. So to get to full, say 350 is the goal for a team, 350 patients. To get to 350 patients, you probably would double that staff over the next year or however soon we can get patients. So for all the folks on the phone, you know, we're open for business. We're seeing patients in those zip codes, and we're happy to, you know, have you make referrals if you think the patient needs it.
Great, great. Let's see. Boy, Judy has got some great questions here. Hope you will explain the patient cost for routine care and how often they typically see patients for routine care.
Yeah, 2 great questions. So one is how we see patients. Our patients tend, again, to be pretty ill. So they have disability and multiple chronic illnesses. And our philosophy is to see them frequently. On average, we might make a medical house call at least once a month. Sometimes it's more than that. It could be every week if someone's really sick or unstable. Deanna and the social work kind of team might visit them initially. We do a phone screen on everyone if they need social work services. And then Deanna might see them often at the beginning, again, every couple of weeks, or once a month if they're active for social work thereafter. So at least monthly or twice a month visits for medical and or social work. And then the costs of that, you know, Steve, we talked a lot in our earlier meeting about kind of the need to pay for all of this. And Medicare fee-for-service does not pay all the costs of the staff I just described. So there's a lot of travel time and social work costs and 24/7 on-call costs that Medicare doesn't cover. And so initially we were thinking about some sort of private pay fee for high-income folks and a sliding scale for lower income. And we ultimately decided to bag that. We decided it was too complicated to try to execute and might be a barrier to entry. So we have decided as an organization to accept, you know, Medicare, Medicaid, dual eligibles, other commercial insurance, and have them pay us for our house call services. And we're putting together other funding from philanthropy, from payers to do some value-based payments, to try to kind of put together a funding mechanism that works overall. So right now for patients and families, there's no extra cost beyond typical co-pays that they pay for office medicine.
Well, as many of the people that have been on some of our other webinars on different topics, COVID-19 is requiring us all to look at our businesses radically different and make changes to address the marketplace. But one of the things that always fascinates me, and I like using programs like yours as inspiration to us all, is because you rarely come out of the gate with, you know, you do all this planning and it's like, oh, this is going to be perfect. This is how it's going to work. But then once you start operating it, you begin to discover the different market pressures and you're making modifications. And so it's a great lesson for all of us is that you've got to be adaptable and flexible. And with that, and this is, I'm curious on both you, Dr. DeYoung, and Deanna, it's, do you have any COVID-19 stories to share with us or some insights that the audience might want to hear about and reflect on? Sure.
There's a long list. I think I'll start off at the kind of high level first, and then we can actually, there's a patient story that we probably should share as well. On a high level, it's totally upended how Capital Caring Health does a lot of our work. So we've had to, starting early March, really think about continuing to provide care for all our patients, COVID-19 patients and non-COVID-19 patients. What visits are going to be televideo and what visits need to be in person? So how do you decide what needs to be an in-person visit if they're really unstable or the family's in crisis, or you can make a better decision because you see them in person? We've shifted probably 80% of our visits to televideo. After the initial visit, the first visit I always like to make in person if at all possible. But after that, you can do, we've learned, the good news is we've learned you can do a lot of follow-up visits by televideo and save on travel time. So that is an efficiency that we've learned from the epidemic. The other big issue for our staff has been protection of the patient and family, but also protection of staff and using PPE properly. So how do you make the diagnosis of COVID-19 in the home? And we've gotten enough supplies from LabCorp that we can do that diagnosis. If you have symptoms, how do you protect your staff and get adequate? There's a decision tree of when to use PPE and when not to use full PPE. And we've had to go through all of that. And then we've had to deal with patients who have symptoms and are sick from COVID-19. And then you have to actually take care of them at home. And we have had a couple patients out of our 50 who have had new diagnosis of COVID-19. And then a number of them in the hospice side, close to 100, maybe out of our 1,400 who are COVID-19 types of patients. So there's both the high level, how do you take care of your staff? And then how do you actually take care of a COVID-19 patient at home?
Yeah, great. Deanna, I don't want to leave you out of this conversation. Any observations that you've sort of seen with the COVID-19 challenges?
Well, I think Dr. Jonge is going to talk about a case that we recently took on to kind of highlight just the strain that our patients and caregivers are facing. And so I'm going to actually defer to you on that one.
Great.
Yeah, but Deanna and I worked on this together. Actually, obviously we'll kind of keep the details confidential and anonymous, but there was a very ill elderly person who was coming out of a hospital, 98 years old, and survived COVID-19. And this person was coming to live with their family. And there was all this work that had to be done before that person even came home to make sure it was a safe environment for the patient, safe environment for the family, all the equipment set up. It was a long list of things just to get that patient from the hospital to the home. And Deanna did a lot of that work and prep work to prepare for that. And then I go to see the patient on a new visit, trying to see them, after they get home from the hospital. You have to make sure you're protecting and have all the right protective equipment, that you can there's a home health aide in that home, working 8 hours a day in close contact, making sure that aide stays safe. And there's family members who are nervous and kind of stressed about having this person in their house. So there's a whole range of medical and social and psychological issues that come up when you have a very ill person in the home. And ultimately, we have kept that person at home. You decide whether they're going to make it, honestly, or whether they need more hospice approach. And that's a decision-making process you go through. So it's a challenge, but it's very doable when you have a good team in place and you have adequate equipment. And I felt safe personally going to see COVID-19 patients. And then I go see patients who, with proper precautions all the way through, who don't have COVID-19. And I think there's good literature that you can take care of both populations safely if you use adequate protection and kind of hand hygiene and all of the other kind of proper safety precautions.
Great.
Do you want to add kind of just in terms of the general approach to managing the kind of COVID-19 patients at home?
Just that this is more of an urgent referral for our practice. And I'm biased, but I think we did a really wonderful job with responding to that urgency and just the distress, because this particular family member was really trying to protect their loved one from returning to a nursing facility. And so it's a huge change for him to suddenly take on all these responsibilities. And I really think that our nurse practitioner who visited today, and they were just discharged recently, and Dr. Jonge visiting very soon after the discharge, and then our on-call coverage has really helped to smooth that transition, which again is massive for our caregivers of those who have COVID or survived COVID.
Excellent. No, and let me get to a bunch of questions are coming in, but I want to make sure that we address a question that we received anonymously from a consumer before the session started, because she didn't want to utilize the sort of the public forum. And her question, she has 3 questions for Dr. DeYoung. How does one know when it's time for a referral to palliative care? Must a referral come from a patient's primary physician? And what is the procedure for getting this done?
Yeah, sure. So palliative care, I want to try to define it first, Steve, because ultimately there's a lot of confusion about what it may mean. Palliative care, the word is to relieve suffering and symptoms. So palliative means to relieve suffering and relieve symptoms. And that job is the job of every doctor and team taking care of a patient. So it's not just the purview of someone who specializes in palliative care. If your primary care doctor can relieve symptoms and relieve suffering, then I don't think you need a palliative care consultation. If you have a good team that can do that. Palliative care tends to be indicated to the person's first question when the current medical provider is uncomfortable or not able to relieve the suffering and relieve the symptoms. Either because they are homebound and they can't get to them, or they're not trained or skilled in doing that, or they honestly don't have the time or emotional kind of intelligence to take care of those issues. But good primary care teams can do palliative care, and then you don't need a palliative care consult. If you want a palliative care consult or your doc wants one, it does require a referral from a primary care provider. So the answer is yes. If it's considered needed, you need a referral so that the teams are working in concert. And then how that would happen is sometimes it's a request from the patient and family, or the doctor or the provider themselves will decide, I need some help, and I'm going to make a referral out to a palliative care provider. I would say at that moment, it's important to think, do I want another kind of cook in the kitchen? Do I want a second team involved? Or do I just need hospice? And sometimes we think the combination of primary care, adding hospice services, if a person has, say, likely less than 6 months to live, is a really natural kind of partnership. And then you get all the benefits of the hospice benefit as well.
Great. Okay. Well, I think hopefully that gives her some guidance on her question. Thank you for that. Let me kind of go down some of the questions that are in the Q&A area. Let's see. Do you plan to expand or franchise this model?
Yeah, those are two good and different questions. So yes, we plan to expand. We'd love to go to other areas of high need. And I've said this to the group in person, that if you can tell me where there's a really high need and demand for this kind of care, I'll take it to Capital Caring Health and we'll see if we can get some staff to serve that area. Practically speaking, it probably needs to be, adjacent or somewhat close to where we're currently serving. And we have to, again, get the volume. If we get our practice up from 50 where it is now to 300 or 400, it's a lot easier for me to make the case to expand the program than when I'm at 50 patients, 3 months in.
Yeah, so I'm hoping that this call and the recording of this call does sort of like, the energy in the room at that last event was, I really felt like the provider community was really behind you guys in terms of, man, let's see, this is something that we need to see succeed. We need, more home delivered primary care, regardless of who the provider is. And so hopefully we can help. I can only imagine the speed bump that COVID-19 has presented. While you offer a great solution, it just seems like we've all pressed the pause button. Yep. And but one thing that's encouraging is that telemedicine and home delivered services are now the norm. Like, whereas they were unusual before, now everything is home delivered, let's see. This is a question that I just happened to glance at in the comments, and try to put your questions in Q&A because it's hard to go into comments, but it says, where have most of your referrals come from? Do you address the needs of family caregivers, i.e. the spouse, through the referral?
Yeah, so those are two big and different questions. So a lot of our referrals have come from, I'll say almost half and half, from some assisted living and senior living communities, and half or more from the individual kind of word of mouth in the community. We have a great working relationship with a number of senior living organizations. I saw Janina is on the line, and we work with Grand Oaks. We're working with Knollwood. We're working with a number in Northern Virginia, Goodwin House, and others. So senior living organizations is good for us because it might give us a little more efficiency and less travel time. But we also serve the neighborhoods around there. And then what the second question, could you repeat the second part, Steve?
It says, do you address the needs of the family caregivers, like
Yeah,
the
so
spouse through the referral?
yeah, well, once before and after we see the new patient, we work with the family, whoever the power of attorney is, whoever the closest family is. Deanna and our NP and our nurse and our whole team is focused on supporting the caregivers to succeed at home. Because if the caregivers have the resources they need and the emotional and skills that they need, then the patients are often stable at home. And if they don't, then the patient can become unstable, land in the hospital or in a nursing home.
Great. Judy Tiger has some great questions today. How do patients and their families keep track of visits and records?
Right, so we have a number of records that we keep on our laptops and electronic health record, and patients and families have a portal where they can come in and view, some of their medical record. That's one way. We also, on every visit, write out, kind of the old-fashioned way, handwritten instructions of medications, changes in the plan, what we touched on, their vital signs, and we give that to them on every visit. And we also provide a vital sign kit to every new patient so they can have blood pressure, heart rate, oxygen, and temperature that they can check, and we give them a little log to track their vital signs at home.
Oh, great. We did have a speaker on an earlier webinar sharing with us the concept of remote patient monitoring. Do you have a formal remote patient monitoring platform for that?
Not formal remote patient monitoring. We actually are a little bit low tech in that we give folks a vital sign kit, and then they check the vital signs whenever there's a problem or where they're going to call us, and we get that information over the phone. And I think the old-fashioned telephone can be very good for remote patient monitoring.
Yeah.
We're using Zoom Health for remote patient monitoring with televideo visits, and that actually is useful. And then a couple of our patients have a blood test monitor at home for Coumadin. It's a blood thinner, and we get their results remotely when they give a finger stick of blood at home.
Great. Noel White asks, are you part of the Maryland Primary Care Program? And if so, which CTO, care transformational organization are you affiliated with? Those are terminology that I've never heard of. So
I'm familiar with the CTOs and Maryland Primary Care as part of the kind of Maryland kind of special payment model that's set up in Maryland. We are not. The answer is no, we're not a part of the Maryland Primary Care Network or a CTO right now.
Okay. If your patient, Susan Rannick asks, if your patient is on hospice with internal feeding and the family requests a consult by speech for pleasure feeding, how do you handle that? Can they secure speech services on their own?
Well, so yes, it's a fascinating question. So people who are very ill, even on hospice, and have a feeding tube, what's one of the few pleasures in life that you want to hold on to? And it's being able to taste food and drinks and kind of enjoy that. So I really try to make sure we allow people to eat and drink until the last day of life, and getting speech to help with that evaluation is good. I think a doc, an NP, or a nurse can do a bedside swallowing evaluation. So if a patient is alert and can pay attention, if I give them a little sip of applesauce, and if I can watch them transfer that applesauce to the back and swallow it, even if they cough a little bit, they may have trouble with liquids, and maybe ice cream and applesauce is better, I give them the green light to take pleasure feeding. You can get speech through a home healthcare agency, but I don't know if speech being part of the hospice team. It's usually not.
Okay. I was just looking at the chat, and this is a very interesting question. And again, guys, you're lucky I'm seeing these questions in chat. Make sure you put them in Q&A. But the question is it possible to care for both COVID positive and COVID negative residents within the same facility? Yeah. I think that's a question. I don't know if you know the answer, but that's one that I kind of hear on a regular basis in these discussions.
Yeah, so it's a tough problem, as you guys all know all too well. It's a terribly high risk situation to be in a nursing home or a group home where there's COVID positive patients with the same staff taking care of all of them. That being said, really, I think pioneering nursing facilities and group homes are taking care of both kinds of patients. And I think the way to do that is to test. So the one I've been working with in the area has been testing patients every 10 days in the entire facility and making sure those who are positive are kept in a different section of the facility with a different set of staff, and with good PPE and hand hygiene and precautions. And I think they're doing as good as possible a job as you can to keep those two populations safe. There are a number of other ways that it's been approached. There are a couple in New York, which has had the big problems. They're creating special nursing facilities and hospital units just for COVID-19 patients. So some sort of isolation is essential if you are going to do that.
Great. Yeah, super challenging. And I imagine as testing becomes more widespread, we're going to discover that all of our communities and all of our neighborhoods have people testing positive. But let's see, Susan asks another question. Did I understand correctly? Do you do your own medical imaging studies like x-rays?
Yeah, so our team of that core staff don't carry the x-ray machine around, but we have two good partners in the community. We use Dynamic Mobile and we use Radiation Physic, and they go out and do x-rays, ultrasounds, echoes of the heart. We can do all of that at home. And we've had some of that done even on COVID-19 positive era. Haven't done it on a COVID-19 patient yet, but some of the companies are willing to still go to the home right now.
Okay. Kim Foster asks, so do patients have to give up their relationship with their established primary care physician to be part of your program? Do you take uninsured patients?
So two big questions. The question number one is yes, we are a primary care program. So if they want to keep their current primary care provider and think that that's working for them, then they would not join our program. We are okay with some overlap, Steve, where maybe they want to have a visit or two, a goodbye visit, or we have close communication and talk together about a handoff. But we are a primary care program, and you can only have one primary care provider. In terms of uninsured patients, Capital Caring Health tries to serve kind of people of all income levels. Our primary care program right now is accepting Medicare, Medicaid, other commercial insurance companies, and we're not accepting pure uninsured patients.
Okay. Let's see. Okay. Is Capital Caring able to provide psych services at home?
Yeah, so there's different levels of psych services, mental health, right? So Deanna actually and our other social worker are very good, as are our nurse practitioner and our geriatrics physicians, I think, do a lot of mental health work. So we diagnose mental health problems, we treat with medications, we do supportive counseling. But if it gets complicated with psychiatry and they're on multiple medicines or they need capacity assessments beyond one doctor, we then will try to refer for a psychiatric evaluation. I'd love to actually have social work therapists who we can refer to. I think there might be some on this call. So I'm happy to kind of find out about more of those. It's hard to get a psychiatrist to make a house call. So that is a very rare resource.
This is from Catherine, and it's more of a policy question, but I think oftentimes because your communication, you might be able to provide feedback. I'm a Medicare approved provider for mental health services. Do you think the telemedicine allowances continue after the distancing requirements, or will the requirements to meet in person resume?
Yeah, it's a great question. I do work a lot with some health policy teams in DC on that and many other questions. Their best thinking right now is that it's very likely that televideo visits will be continued and paid for, probably with different rules. So for example, one thing I've heard, which I thought made some sense, is that initial visits might need to be in person, but that they would have flexibility for follow-up visits to allow for televideo and billing.
That makes a lot of sense. This is a very insightful comment from Dr. Walter Fanberg, who is the owner of Arbor Place, a small dementia care community. in response to the earlier comment, in a group home setting for persons with dementia, it is possible to care for both COVID positive as well as COVID negative within the same facility. Not possible to isolate the positives in their rooms without over sedation. And again, he's referring to dementia and residents, which the social distancing is next to impossible with that population.
No, it's really hard. I think he makes an incredible point, because their judgment about face masks, about wandering, about moving around, about distancing, all of that insight is often lacking. And so some sort of physical separation is needed, but it's hard to implement.
Kim Foster says, is a case manager at Inova Fair Oaks Hospital, what is the referral process to get a patient in the program? Who would I contact?
Great. So I'm going to give you two numbers, one for Northern Virginia and one for Northwest DC and Chevy Chase. The one for Northern Virginia, first you have to look at our website, which is capitalcaring.org/PCH, as in primary care at home, capitalcaring.org/PCH. In Northern Virginia, our office number during the week is 703-333-6969. And if they're in our zip codes, if you look at our website, if they're in our zip codes, then give us a call. And for DC and Chevy Chase, it's 202-844-4922. Again, check that website to check the zip codes before you call. And if you're really close, and I'll say this even in public, if you're right on the border and it's a group home or it's an assisted living or there's a strong, important reason, we've made some exceptions for people who live very close to our borders.
Okay, and I typed those into the chat, guys, which I'll be sharing with people, but when I send an email out, I'll make sure to include that as well after the event. Okay, let's see. Is there an age limit or age range to receive your service?
Yeah, generally, yes. We're doing 65 plus. So it's a geriatrics program. It's focused on elder care. Most of our patients are in their 80s and 90s and 100s, but we do take people down to 65.
What are the foreign language? This is from Paula Phillips. What are the foreign language capabilities of the staff?
So on our immediate direct staff, we do have folks who speak Spanish fluently. Deanna, do we have someone who speaks Korean on the staff? Not now. So English and Spanish on our staff, but our Capital Caring Health has a full translation service that can speak 100 plus languages to do translation.
Great. Let's see. Have there been patients who you would have not or would not accept, and why?
Well, yeah, it's a really good question. So one is a kind of simple geographic issue. We are restricting ourselves to certain zip codes. So there's a huge need, an ocean of need out there, and we have to, because we want to be viable for the long term, we are restricting ourselves to certain zip codes. Folks who are, again, under 65, we've actually declined to take at this point. And then the only other one that comes to mind is in the intake process, when they make a referral, if they don't want to give up their primary care doctor, we actually are not able to accept them. And the last one is a more tricky one. It's, are they really willing to abide by the rights and responsibilities of our program? Do they accept how we do things? And it's a little different in a house call program in terms of appointments and follow-up and engaging the providers and their families. So if it's someone who doesn't want to kind of work with us on our rules of our program, we would probably decline to work with them, but that hasn't happened that I can remember. Generally, people find us flexible and we're willing to work with them.
Yeah, I think you have created some limitations to your program. One of the things that I'm hearing, and that I see in other new organizations as well, is the willingness to be flexible, because you're discovering what are the limitations of your program. And so I think I could see where, like you said, if you're on the border, hey, look, you're not in the zip code, but you're close, we'll try to make it happen. From Meryl Schaefer, do you run into situations where family members become overwhelmed with all the medical paperwork and might need the the services of a daily money manager. While that's that is a very good, very focused question, I think it also speaks to the wide variety of needs, because you guys are going into the home, you're getting to know the clients on a personal basis. It could be daily money management, it could be grocery delivery services, it could be having a companion in there. How does that all work? And I imagine, Deanna, this is kind of,
pump that to Deanna.
Yeah.
Well, thank you for punting it to me, because I was going to say that's exactly why social work is on the team. For many of our patients, all walks of life, I'm here to support them, whether it's a quick referral or whether it's weekly sort of visits and conversations around services that will be helpful for them to age in place and age successfully.
Great. A couple of follow-up questions. And I think this is one where the Capital Caring Health name often confuses people. It says, so if somebody is in good health and older, they can use you as a primary care physician, correct?
So yes, with one caveat: if they're in good health and they're functionally independent and they're driving around and they can get to their office doctor, we can't bill Medicare for house calls in that situation, because in Medicare you have to justify that house calls are needed. So there's some reason why it's a challenge to get to the doctor's office. So our primary care program, Steve, is not for healthy elders. It's more for people with some serious illness. It might be congestive heart failure and diabetes or hypertension, mild dementia. You know, they're not dying necessarily, and they're not even gravely ill, but some chronic illness that requires close attention. That's who we're focused on.
Okay, great. And then one of the attendees said, repeat please the association that provides the 100 language services. Translation is written, spoken. Does the service provide that? So just maybe some more details on the language interpretation.
So I know that Capital Caring Health has a translation service for verbal connections with dozens of languages. Deanna, you might be able to add some detail to that. I don't know that we have something that translates into writing everything, although we could use Google Translate for that. Deanna, what do you think?
I would provide the same information. Nothing to add there.
Okay, great. And then Judy Tiger just wanted a little bit more clarification on the rules of, you know, the the guidelines of the client. Maybe just repeat that again.
Sure. So, I mean, and I didn't go into detail on that. So what we call rights and responsibilities. So patients and families have rights, and we have kind of this list of what they can expect from us, you know, prompt service, ethical service, 24/7 availability, kind of fairness in our billing of their insurance, making sure that they have a team to take care of all their needs. And so that's what they get from us. And then the responsibilities is that they're going to be home when we try to make a house call. They're going to have a safe home environment for us to visit. They're going to be, they're going to live in our zip codes and meet our age requirements. So not a lot of strict responsibilities, that they will treat our staff with respect, right? You know, no verbal abuse, or certainly no physical safety problems. So we're happy to take care of people with really complex mental health, physical health, you know, problems, social isolation. We just need a partner that's willing to, you know, kind of work with us on a day-to-day basis.
Great. And one of the comments that again came up at the live event that we did, and it's come up multiple times with some of the other guests that we've had on this series of online discussions, is, okay, so, you know, right now, Capital Caring Health has a tight geographic restriction in DC and Northern Virginia. There are other providers out there that provide home-based care. You know, we featured Doc Talker. There's Dr. Simmons, and Dr. Sinha is doing things. That the interesting thing is that those of you who were truly providing home-based care for many years before COVID-19, it's interesting to see how every medical practitioner is now scrambling to provide some kind of home-based support just so that their business will survive.
Yep.
Um,
Yeah, it's an interesting question of whether a lot more providers will try to keep their patients at home. My wife actually works at the VA, you know, as a physician, and they're struggling to figure out how do we shift all of this care to the home that was previously coming into the office. And I think there's going to be a lot of permanent changes in that direction once this settles down.
Great. This is another follow-up to your comment about sort of lower functioning versus higher functioning patients. But given the fact, like, let's pretend that it was an independent living senior community, somebody who was relatively healthy, it seems to me like that might be an ideal patient, even if they were a little healthier than your
Sure.
normal demographics.
Sure, yeah, and we actually are eager to serve independent living and assisted living, but independent living folks who have chronic illness or some sort of illness. Usually, if they're 100% healthy, they're probably not in a CCRC. But if they have an illness, and again, if in this day and age now, Steve, if they're reluctant to go to an office facility because of COVID-19, they have some sort of underlying condition, that would be a great reason to have them be a house call patient.
Great. Well, it looks like we're getting close to the end here. I think we've been through most of the Q&A, but the other doctors that I've had on recently in the past week, I always sort of like getting some words of wisdom from people on the front lines in what can we do personally to protect ourselves, to protect our clients, and to get through this challenging COVID-19 process. Any words of wisdom on things that we should be doing?
Sure, and I'll actually ask Deanna to add to that in a minute. I just want to first acknowledge, Steve, how hard this time is. This is really hard. I mean, it's hard on a personal level for everyone to be losing human contact and human touch. And being on screens like this for much of the day, it is really hard. It's hard for physicians, providers, and non-providers. And just to acknowledge that it's really hard. And so I guess my first kind of word of wisdom would be to make sure people take time to get away from the computer and email and Zoom and kind of find time to protect themselves as providers or whatever work people are doing in the aging world, and to kind of do something restorative, whatever it happens to be for you, is to try to find time for that. Because I think it's emotionally very draining to go for 7-8 weeks with some fear of getting sick, and also without the human contact, daily professional contact that we're used to. So that's on the personal side. On the professional side, for patients and families, there's two things that come to mind. One is, recognize there's a lot of illness other than COVID-19 that these patients have. And we don't want people to suffer because of our fears or the barriers of COVID-19. And there's patients in our practice who we recently have had problems with, say, acute loss of vision, their eyesight getting downhill very quickly. And we're having trouble getting them to see an eye doctor because of rules around quarantine or other things. Or there's people who have medical issues with their medications and they can't get their controlled substance for pain relief because of some sort of barrier to quarantine. I think we have to try to balance all of those rules with making sure we address the other medical concerns that patients may have. I guess one other silver lining is that it's prompted people to have conversations about end-of-life care. Do I want to be on a ventilator? What kind of care do I want at the end of life? And I think I would encourage people to ask those questions and make sure people are prepared ahead of time for something that might be very serious, rather than wait for it to kind of happen and be a crisis. I'd much rather people be prepared ahead of time.
Great. And
anything to add on that?
No, I think that was all that needs to be said, really.
Great. and I knew that if I said that, you know, we're going to be leaving you soon, that a few more questions would come in. This is strategy. I'm really getting good at prompting questions. So we got a few more. Do you refer your patients to outpatient therapy services, physical, occupational, and speech therapy? That's from Katie Biskey.
Yeah, we do both home-based skilled services for home nursing, home PT, and OT. And then up until COVID-19, there's a number of patients who might benefit from going to outpatient services. So our team would be the referring provider for rehab and skilled nursing.
Great. And then Dr. DeYoung, clearly your services are needed for chronic or complex post-discharge care in the home. And with the value-based care, more than ever, the health systems are concerned with the quality of the outcome. Capital Caring Health can be a valued partner with such systems. So are you formalizing relationships with health systems in a referral or shared risk format? Hopefully I read that word for word. I'm hoping
whoever wrote that question is really insightful. The answer is yes. Actually, Capital Caring Health sees our program as a way to do value-based payments with local Medicare Advantage partners, with CMS directly. We've applied to be direct contractor for CMS to get paid based on preventing hospitalization, Steve, and reducing total costs of care. So our program, I think, can really, and it's been proven that home-based primary care can reduce costs by 20 or 30%. And so payers and health systems are interested in funneling patients to this kind of practice.
Yeah, that would be great. And then Barbara Putnam, I botched her name the other day, says, how can we move forward in regards to medical care, outpatient, knowing the end result could allow COVID into our community, which infects dozens of individuals?
Just want to make sure I understand the question. Go with outpatient medical care and thinking that that would then lead to COVID-19 in the community.
Yeah, how can we move forward in regards to medical care, knowing the end result could allow COVID into our community, which infects, so I guess maybe somebody being discharged?
Yeah, so you know, there's two reasons, I think, ways people are at least fearful of. People are fearful that people come out of the hospital to the community and create sources of infection in the home.
Oh, okay. She's clarifying. It's in regards to statement about needing outside services like eye care or what have you.
Right. So I think, again, just to be maybe a little bit, hopefully reassuring, there's a lot of good evidence that with proper precautions, hand hygiene, mask, 6 feet of distance, using gloves, you can be very safe going to a provider's office, taking care of patients there and having that patient go back to the home or back to the assisted living, wherever they happen to be, safely. We don't need to kind of be siloed into sealed off rooms in order to be safe. With proper precautions, mainly hand hygiene and not touching your face and not being in very close physical contact, healthcare workers can be safe, as can the community.
Okay, great. And well, she's got a couple of follow-ups. What about surfaces and clothing?
Yeah, so there's a lot of knowledge out there about the virus can exist for 2 or 3 days on very hard steel surfaces. I'm not familiar with any evidence that there's significant rates of infection where people actually get sick from touching a grocery bag or touching clothes. The 99% plus of these infections occur from close physical contact with another person, and either body-to-body contact or droplets or secretions that then you touch and you put to your mouth or face. So it's very, there's precautions about surfaces and you should keep things clean, but the vast majority of the infections is from close physical contact with other people.
Great. Well, man, I'm amazed at how fast an hour goes by when we have audience participation like this. I really appreciate both of you for being on, and I hope we can do this again in person, but also I hope we can do this again and get some updates on the growth of your program and help spread awareness to any changes or developments that the program has. For the attendees, I'm going to share all of the chat You'll get that in an email so that you can have some of the contact info and some of the resources that you've been sharing. You'll get a recording of this. And then I just, for those of you we've got 2 really good webinars in the next day. Tomorrow, we are doing a moving, downsizing, and decluttering in COVID-19 and beyond roundtable. And that should be a fascinating discussion. We're eager to have as much input on that as possible. And then on Friday, we've got the CEO of a tablet that was created in a retirement community in Virginia. It's called Birdsong. And we'll learn about that tablet and how that technology helps the residents. In addition, I have a University of Maryland professor who specializes in gerontology and voice-activated technology, Amazon Alexa and Google Voice and those types of technology. So Friday should be a fascinating discussion as well. I'll send you links to those, but I just wanted to give a commercial. Dr. DeYoung, thank you so much, and good luck with your program. We are rooting for you, and we really want to see this expand all over the DC metro area and see other health providers replicate what you're doing.
Thanks, Steve. Goodbye to everybody. Hope I see you in person soon.
Okay, talk to you soon.